Welcome to the next module in the Learning Ultrasound and Critical Care program, and this one is on above knee deep vein thrombosis. My name is Arvind Rajamani. I am an ICU consultant at Nepean Hospital in Sydney, and I have to confess I am not an expert in vascular sonography. So I'm not an expert on the diagnosis of DVT, but I can tell you that I've done enough of them to be reasonably confident that I wouldn't be able to, I won't miss a major DVT, which is finally what you're really interested in. What you're interested in is to capture those DVTs that are responsible for pulmonary emboli. And we know that 90% of pulmonary emboli are caused by above limb, lower limb DVTs. And we should be able to capture these even with basic vascular venous Doppler training. The relevant anatomy. There are two important veins. One is the common femoral vein, specifically at the level of the saphenofemoral junction, and the other is the popliteal vein in the popliteal fossa. So this is the anatomy. And you can see below the inguinal ligament here, you have the common femoral vein, which is formed by a combination of the great saphenous vein that drains into the femoral vein here. Okay, the great saphenous vein is draining into the femoral vein. The femoral vein itself is formed by the superficial femoral and the deep femoral veins. So all three veins join together to form the common femoral vein. So this is the most important part of the anatomy, or rather one of the veins. The other vein, as I said, is the popliteal vein, and this is formed by the various calf veins joining together behind the popliteal fossa to form the popliteal vein. Now the popliteal vein courses up along the thigh, and that's where it's called the superficial femoral vein, and it's an unfortunate term. Okay, the term superficial femoral vein seems to indicate that this is a superficial vein. No, it's not. It's actually a deep vein. So a lot of people have now just started calling this the femoral vein. Okay, so the popliteal vein forms the femoral vein in the thigh, and it keeps going in and in, and then it's joined by the deep femoral vein, and the two of them form a junction here, and then that is formed by that is joined by the great saphenous vein to form the common femoral vein. What you are interested in is in clots at this level, at the common femoral level, and the popliteal vein. Okay, and of course anywhere along the course here. You are not really interested in the below knee DVTs, although these are all deep veins. The incidence of pulmonary embolism from these veins is relatively small, that you can ignore it, and the technical challenges of scanning these veins is actually enormous. It's very difficult to scan below the calf or in the calf. Okay. However, you do have to know that if you do find DVTs of below the knee DVTs, then 1/3 of them extend above the knee in a week or two. Therefore, surveillance Doppler is indicated if you're not going to treat it. So at the just below the inguinal crease, the femoral vein is present in the inguinal in the femoral triangle, and the organization of the vein, artery, and nerve, the femoral vein, the femoral artery, and the femoral nerve, from medial to lateral are VAN. So vein, and then artery, and then nerve, in that order from medial to lateral. So this is a picture of the saphenofemoral junction just below the inguinal crease of the right side, and you'll find that this is a beautiful Mickey Mouse sign, and this is something that you always have to get. So this is my first image. Okay, when I do a right lower limb DVT scan, or lower limb DVT scan, the Mickey Mouse sign is what I'm looking for, and the head of the Mickey Mouse is the face of the Mickey Mouse, the common femoral vein, and the two ears are formed by the femoral artery and the long saphenous vein. One very common problem that happens is that the pressure of the probe is easily enough to occlude the long saphenous vein, and you often keep searching for it, and if you just release the pressure a little bit, you can get it back. Okay, that's one. The second, sometimes if you're in an oblique angle, then you may only get the one or the other, so one of the two ears, and if that happens, then you might have to rotate the probe and correct the angle a little bit. Sometimes you might have to tilt up a little bit or tilt down a little bit in order to get the Mickey Mouse sign. But you always have to try and get all the three components of the Mickey Mouse sign in the same image, and sometimes it may not be possible, but most of the time it should be possible. Okay. At the popliteal vein, the anatomy is in the popliteal fossa. The popliteal vein is always posterior to the popliteal artery. It's anatomically, but because you're actually scanning from behind, the vein is more superficial to the artery. So the vein is the one that comes closer to the probe. Okay, and you have mainly these two structures. You have the popliteal vein and the popliteal artery, and you'll see both of these as anechoic structures in the popliteal fossa. And if you don't see them, you just have to scan superiorly and inferiorly, and just sweep around in the popliteal fossa, and you won't miss it. And so, just like with the femoral, with the saphenous vein in the groin, the popliteal vein, the weight of the leg is actually hitting against the probe, because you're scanning from behind. And if a patient is lying in bed like the ICU patients, then the gravitational weight of the leg is actually pressing down against the probe, and this is often enough to compress the popliteal vein. And you'll be searching for the vein and you won't find it, and that's because you're actually doing a compressibility test already. So what you might have to do sometimes is to just with your other non-scanning arm, lift the thigh up towards the ceiling a little bit to relieve the pressure, or with the scanning arm, just relieve the pressure, just relieve the pressure of the probe on the vein. So just withdraw it slightly from the skin, and that might be enough to uncollapse the vein or re-expand the vein. Now these are the four principles or four modalities of DVT scanning. You look on 2D echo, you look for echogenicity of the vein. You then press with the transducer and see whether the vein is compressible, and then you apply color Doppler and pulse wave Doppler to look for filling characteristics, including velocities. Okay. Now a normal vein should be completely anechoic, so it must be black. It must be fully compressible with very mild amount of pressure that you apply with the transducer. You mustn't be needed to apply too much pressure at all, and it must be fully compressible. If you apply color Doppler, then you should have a nice, beautiful, smooth, uniform filling inside, and you'll have respiratory variation of flow velocity. So if the patient is breathing in and out, inspiration and expiration, then there will be a change in a phasic variation of the velocity if there is no occlusion of the proximal venous system. So, okay, so if all the proximal veins, if the veins proximal to the probe location are patent, then you will have phasic variation. Similarly, if the veins distal to the probe location are patent, then you will have an increase of velocity and an augmentation of flow velocity when you apply pressure on the patient's calf with your hand. So if you press on the patient's calf lightly, immediately the flow will increase. That's the characteristic of a normal vein: anechoic, fully compressible, uniform filling, and you'll have variation, phasic variation of respiration and augmentation. Now you come to a DVT, and you may be able to see echogenic material in the lumen. A DVT typically is not compressible. The vein is not compressible, or it may not be fully compressible, so it may only be partly compressible. If you put color Doppler, you may see a filling defect, and you may notice that there is a lack of respiratory variation or phasic variation with respiration, or poor augmentation or no augmentation with calf pressure. One thing you may have noticed is that I used a lot of maze. What does that mean? This is not 100% foolproof. For example, echogenic material in the lumen. Now, if you have a fresh DVT, you may not be able to pick it up because it's hypoechoic to sometimes even anechoic. So this, and the probes that we have for bedside vascular sonography are not the high-end ones, so we may not be able to pick up subtle abnormalities such as a fresh thrombus. Okay. Then, compressibility, a vein may sometimes, you may have a DVT, but because of technical problems that we do, we may not be able to compress the vein fully. Color Doppler may have problems because you know that Doppler is angle dependent, and if you have if the transducer is perpendicular to the vein, to the flow of the vein, then you will have a filling defect all the time. Okay. Second, you may not appreciate the filling defect, so it may not always be there. And pulse wave Doppler relies on quite a lot on the patient's on the transmission of the thoracic pressure to the vein, and therefore, if the patient is not taking a deep enough breath, or the abdominal pressure is elevated because of, say, pregnancy or a tumor or ascites or something, then you may not have an adequate transmission. Calf pressure, once again, augmentation may not be possible, may not happen properly. So all of these things have some fallacies, and perhaps the most reliable sign of a DVT, the most important sign, is the compressibility. You have the compressibility with the probe transducer, with the transducer head. If it's not compressible, then you strongly have to suspect a DVT. Okay. Now, one comment about the gain settings for the echogenic material. Now, remember that gain can create noise and create a lot of echogenicity within vascular structures when there is none. How do you optimize the gain? Make sure that the tissues, the adjacent tissues do not have any noise, do not have any signals. Second, compare it with adjacent normal structures. For example, if you know that the artery does not have a thrombus, then adjust the gain in such a way that the artery is anechoic, and, as I said, the subcutaneous tissues and the adjacent tissues do not have excessive noise. Okay. So now you have the probe in your hand and you're going to start scanning, and you've chosen a particular spot. So, for example, my favorite spot to start off with is always the saphenofemoral junction. Okay, what is the sequence of scanning? The first thing is a 2D image in the transverse axis. Okay, so I always start off in the transverse axis on 2D, and one important thing is that the convention is that the probe marker always faces the right side, always faces the 9 o'clock position. So it always faces this side, the right side of the 9 o'clock position. So start off with transverse 2D, and then you look for echogenic material within the lumen, and then you press the vein with the transducer and look for compressibility. Next, you put color Doppler. Okay, and you may have to tilt the transducer a little bit to create an angle to the flow, and you look for color filling within the vein. Then you put pulse wave Doppler in the center of the vein, and you look for phasic variations on respiration. If you don't notice that on tidal respiration, you ask the patient to take a sniff. And then next is you look for augmentation on calf compression. Finally, you rotate the probe longitudinally, and you do all of these, but you don't look for compressibility, and you don't look for the pulse wave. You don't look for compressibility mainly because with the longitudinal axis of the probe, orientation of the probe, the pressure may not be transmitted completely to the vein, and you may not be able to demonstrate full compressibility, and that doesn't mean anything. Okay, so you look for all the other things, especially you look for echogenic material, and you look for color filling within the vein. This is what you do at any probe location. Okay, and you do this at multiple levels along the lower limb. Having said that, I don't routinely, so I flip over from the transverse to the longitudinal axis at the saphenofemoral junction and the popliteal, but I often don't do that in the mid thigh and the lower thigh. Okay, I just do this. I look for the compressibility in the mid thigh and the lower thigh, and sometimes if it's not compressible, If it's compressible, I even ignore the color Doppler in the mid thigh and the lower thigh. But if it's not compressible in particular, then I put color and look for that. And I may also look for phasic changes, and especially the calf, the augmentation at the mid and lower thigh. But mainly at the saphenofemoral junction, the popliteal, I do everything very scrupulously. So what are the normal findings on 2D? Now this is a picture of the internal jugular vein in the neck, and I know that this is a talk on lower limb DVT, but I've taken the liberty of putting a neck vein. Now this is the internal jugular vein here, and this is the common carotid artery. And what you do is you apply pressure. So first of all, on 2D, they're both nicely anechoic without any echogenic material. And then you apply pressure on the vein. And when you apply pressure on the vein, you can find that here, the IJV, the internal jugular vein, has completely compressed. And the carotid artery remains nice and circular. So this is an example of complete compressibility. And there's no clot at all. On color Doppler, this is now the lower limb, and on color Doppler of lower limb, what you find is you have this beautiful bifurcation. Now, don't be fooled that red is artery and blue is vein. The convention on color is that blue is always away from the transducer and red is towards the transducer. Okay, flow of blood, if it occurs towards the transducer, it will be red, and if it's away from the transducer, it will be blue. So you can make, depending on how you tilt and orientate the transducer to the blood flow, you can easily make a vein red or blue, the same vein red or blue, and the same artery red or blue. Okay, so in this instance, blue means it's going towards the transducer. Oh, that's interesting. Here blue is going towards the transducer and red is going away from the transducer. That's the color map, and it tells you what the colors above and below are towards the transducer and away from the transducer. Okay, and this is the artery here. This is the vein, and it's bifurcating, and you can see how beautifully it is filling without any filling defect. On the other hand, in comparison with the previous vein, you'll see this filling defect here. So you put color Doppler and you find that there is a filling defect within the vein. So, and if you notice carefully, you have that echogenic material along the lumen as well. So this is an example of a common femoral vein DVT with a filling defect on Doppler, color Doppler. Now, coming to pulse wave Doppler now, you have to place the pulse wave Doppler, the sample gate in the blood vessel of your choice, and in this case it's in the artery, and in this case it's in the vein. Okay, you can see the sample gate here, and then you align the probe, and depending on whether the blood flow is going towards the probe or away from the probe, the graph of the velocity will be either above or below the baseline. Now, an arterial arterial flow velocity wave will be typically monophasic. That is, it's either towards or away the baseline. In this case, it's all going here. It's monophasic, whereas the findings in a DVT, you may have echogenic material within the vein. Can you see that here? It's very, very, very subtle. It's very subtle. Okay, again, just see this. With compression, it may not compress, lack of compressibility, and that's the most important thing. And one thing you'll notice here is that, look at the artery. It has distorted its shape it's become slightly oval, and even then the vein is not compressible. Okay. Now the echogenic material within the lumen, you always compare it with the adjacent artery, and obviously assuming that the artery does not have a thrombus either. You confirm it with color Doppler as we saw it, and then you have false positives and false negatives. False positives can be because of increased gain, but then everything will be brightly echogenic. Now, this is where the money, now we come to the money slide. Point of care above knee vascular ultrasound. So what are we going to teach you and what should you be doing? The most important thing you should be doing is this thing, which is 2-point compression in the limb, in one limb. Okay? The first point of compression is at the femoral vein at the saphenofemoral junction. Is it compressible? Is the femoral vein at the saphenofemoral junction compressible? And then is the popliteal vein at the popliteal fossa compressible? These 2 points, the compression at these 2 points is the most important part of point of care ultrasound. You also have a few ancillary tests. A, is there any echogenic material in the lumen of the vein on 2D ultrasound, Is the femoral vein compressible along the mid and lower thigh? We've already talked about proximal and distal at the SF saphenofemoral junction popliteal fossa, but in the middle, is it compressible? Then on color Doppler, is there a filling defect, or is there uniform filling, or is there a filling defect? And then on pulse wave Doppler, do you have augmentation of flow velocity with calf compression, and do you have a phasic variation on respiration? These are the 5 ancillary tests that you do. Remember, these ancillary tests are not essential for the diagnosis of DVT, nor do they rule it out, but it can be helpful when you have a sort of when it's a little bit difficult, when the 2-point compression is not completely certain. Now let's go on to the technique of how you actually do this. And we've covered a lot of the theory behind this, so I'm just going to tell you the step-by-step practical aspect of doing the femoral vein Doppler. Firstly, patient position must be supine with the leg extended and mildly externally rotated. The probe is obviously the linear probe or the vascular probe, but in fat people you may need to take the curvilinear abdominal probe. Okay, but the initial probe of choice is the linear probe with a vascular package. You always start with a 2D mode, and you always start with a probe in the transverse orientation with a probe marker facing the 9 o'clock position, and this is for both legs. Okay, whether it's the right leg or the left leg, it's simple. The probe marker always faces the right side to the 9 o'clock position. Then place the probe just below the inguinal crease, perpendicular to the skin, and search around. You might have to move the probe up and down, cephalad, chordad, medial and lateral, till you identify the Mickey Mouse sign, and you'll have to make sure that all the 3 components of the Mickey Mouse, namely the face and the 2 ears, which is the femoral artery, the femoral vein and the saphenous vein and the femoral artery, are all seen in the same image. For this, you might have to rotate the probe slightly one way or the other in order to get all 3. Then, once you've got this, move the probe from medial to lateral, so that the vein must be at the center of the image. This is crucial, because when you're going to do the compressibility, you have to make sure that the entire force or the pressure of the probe is on the vein that needs to be compressed. So there's no point having the vein in one corner of the screen. So move the probe in such a way that the vein that is going to be compressed is at the center of the image. Then you press the vein firmly in an anterior-posterior direction, and you look for compressibility. Okay, this is the primary question: is the saphenofemoral junction compressible? And the femoral vein must completely flatten or compress at this location. The tests are: you look for echogenic material within the vein, you put color Doppler, and for this you might have to tilt the probe mildly cephalad or chordad in order to create the angle between, in order to make sure that the flow comes either towards or away from the vein. away from the probe. If it's completely perpendicular, you might have zero flow recorded by the transducer. So color Doppler looking for a uniform filling or a filling defect due to a DVT. Pulse wave Doppler, you position the sample volume of the pulse wave in the middle of the vein and you're looking for phasic variation, that is inspiratory expiratory variation of the velocity. Okay, and augmentation, you have calf compression, so you mildly squeeze on the patient's calf and there must be an increase of velocity. Now I forgot to tell you during the pulse wave Doppler slide, now there is no magic number for the variation in velocity. Okay, you must just find a qualitative change between inspiration and expiration. There is no number of 10% increase of velocity or 40% increase in velocity or anything like that. And the reason for that is that A, the respiratory effort between two patients will change, might be different. B, remember that the phasic variation depends, it's going through, being affected through veins that are going through the pelvis and the abdomen, and depending on the abdominal contents, for example pregnancy or tumor or ascites or something, you might have very little transmission of the thoracic pressure to the veins. So there is no magic number for the amount of variation that you need to see, but there must be some variation. Augmentation with calf compression, again there is no magic number because it depends on how much pressure you're applying and the and if you have a fat patient or a patient who has a long-standing edema, you might not have that much pressure. So, but there must be some augmentation. Okay, these are the ancillary tests. Then you rotate the probe so that it's in the long axis. And once you rotate the probe and it goes to the long axis, once again you look for these two things. You look for echogenic material and you look for color Doppler filling of the vein. For the popliteal vein, the patient position is slightly different. Apart from this, everything is the same, but the patient position is slightly different. Here the patient is supine at the hip, and the lower limb is slightly externally rotated at the hip, just like in the femoral vein. But at the knee, you have to flex the knee 20 to 30 degrees. Otherwise, you will not be able to reach the knee, reach the popliteal fossa. You have to support the thigh with your non-dominant hand, with your non-scanning hand, sorry, if required. Because if a patient is conscious and has good muscle tone, then you might ask the patient to keep that position themselves. On the other hand, if a patient is unconscious on the ventilator, for example, you might have to support the thigh in this position so that the knee is flexed, and you might have to do this with your non-scanning hand. If it's a fat patient and you just can't manage it, then you might have to call for assistance. You might have to ask a nurse or a doctor to hold this for you. Again, the same thing. Probe is transverse. It's a linear probe usually. Sometimes you might need the curvilinear abdominal probe when you have a big fat popliteal fossa, but otherwise it's usually the linear probe with its transverse, and again it faces the right side for both legs, which is the 9 o'clock position for both legs. And now you place the probe perpendicular to the skin in the popliteal fossa. And normally you can just immediately see the popliteal vein, and if you can't see the popliteal vein, you can see the popliteal artery. It might be because you're already compressing the vein because of the weight of the leg falling on the probe. So you might have to just withdraw the probe hand a little bit, and immediately the vein will come into view. If the vein and if the artery and the vein don't come in view in this, you might again have to move the probe up and down a little bit in the popliteal fossa till you see the vein and the artery. And same thing here, you have to make sure that the vein is at the center of the image so that all the pressure that you're going to apply with the probe is transmitted to the vein. You press hard in the posterior anterior direction, and you might have to support the thigh with your non-scanning hand while you do this. So you might have to apply counter pressure with your non-scanning hand in order to maintain the pressure. And the vein must obviously, the popliteal vein must completely compress or flatten. Okay, this is the technique. Now, the ancillary tests are exactly the same as the other one. So there's no specific thing. Echogenic material, color Doppler, pulse wave Doppler, looking for phasic variation and augmentation with calf compression, and rotate the probe to the long axis, which may be a little bit tricky in the popliteal fossa, but you will always have to attempt it, and once again do color Doppler. Now, there are some useful tips for one common question that is asked. Now, when the vein is not compressing, what do? Okay, so you've done all the right things, you've kept the probe in the vein in the middle of the image and so on, and you've applied counter pressure, and then you press hard, and the artery actually distorts, and the vein has not flattened completely. What could be the difference? What could be the causes? First of all, you may be happy suddenly, I've got a case for my logbook. Okay, I've got a DVT, I've got my answer, but prior to that you have to consider various differentials. One, it may actually be a DVT and you may have a case for your logbook, but try and confirm. Okay, look for echogenic material in lumen. Look for incomplete a filling defect on color Doppler, and look for the lack of phasic variation or the non-augmentation of the velocities and so on. Sometimes when you have a non-occlusive critical occlusion, you may actually have an increase of flow velocities at that particular site. Okay, so be mindful of that. That could be one of the supporting features for you. But there can be other conditions apart from a DVT. There can be other conditions, and you always have to make sure that you rule them out, because remember, the implication of diagnosing a DVT means that you have to consider anticoagulation. And anticoagulation is not harmless. It comes with a great deal of risk of bleeding, which and you have to be doubly sure before you confirm a DVT and start something that is potentially harmful for the patient. So, what can be the differentials? One, the pressure, that's compressing pressure, is not enough. So you haven't done your job. You haven't had your breakfast or your lunch, and you haven't pressed hard enough. Okay, and this may be because you're not centered. You haven't centered the probe on the vein. So make sure you move the probe in such a way that the vein is in the middle of the image and is going to get all the pressure from the probe. Second, I forgot, and I haven't mentioned this before. If you're tilting, if you're able to get an image only by tilting the probe a little bit, rather than having it perpendicular to the skin, that may be, that pressure may not, you'll have to actually apply the pressure in the direction of the tilt of how you're holding the probe. You can't suddenly make it perpendicular and change it. Okay, but the best way to do it is to have the probe perpendicular, so that all the pressure will be transmitted to the vein. If the probe has slipped laterally, then the compressing pressure won't be enough. But the way you diagnose this situation is that suddenly the vein will be off center. It won't be in the middle. So that's easy. Not enough pressure, and I've already told you how much pressure to apply. You apply enough pressure to not flatten the artery, distort the artery just a little bit. Then you may be mistaking the artery for the vein. You may look at the artery and say that's the vein, and clearly the artery is not going to be easily compressible. You can compress an artery with a huge amount of force, but that amount of pressure, you'll have to have warning bells anyway, warning sign, alarm bells anyway. I don't really need this much pressure to compress a vein. Is there anything wrong? And you always look for where you have to think of whether it's an artery, and the easiest way of diagnosing whether it's an artery or not is by putting color Doppler and pulse wave Doppler and look for the flow velocity characteristics. An arterial flow will be nice and monophasic, so it will be, and so you won't have anything like respiratory variation. The velocities will be quite high, and so on. Lymph node can be mistaken for vein, and once again with this, put color. If it's a lymph node, you should not have any flow. But remember, if you have a DVT and a completely occlusive DVT, you won't have any color either. So that doesn't really solve your situation. The best thing to do is image the structure in the long axis. So two perpendicular planes. A lymph node is a round structure, spherical structure. Therefore, it will always remain round in both planes, both perpendicular planes. On the other hand, a vein is a tubular structure. So it will be circular in the transverse axis, and it will be long and cylindrical in the long axis. So that's something that you have to do. So in summary, what we are looking for is an above knee lower limb DVT, but the same principles hold good for neck veins, for example. Okay, you apply, so it's, but what we're mainly looking for is the above knee lower limb DVT. You always adjust technical factors in the machine, and this is, just like with every other modality. And in this instance, the gain, the depth, the choice of the transducer, and all that. Okay, but mainly the gain. The main test that we are looking for is 2-point compression in each lower limb. So there will be 4 points compression in all. So saphenofemoral junction, popliteal fossa, and then on the other sides, SF junction, popliteal fossa. And the ancillary tests include echogenicity within the lumen, color Doppler, and pulse wave Doppler.